We can start now, sir. We can start.
Yeah. So, good evening. All eminent faculties. Our chairperson, Dr. Yatin Mehta, our respected Dr. Deepak Malviya, Dr. Vibhukal Das, Dr. Kapil Jirpe, Dr. Ranveer Tyagi, and Dr. TNS. And good evening, the audience. So, CRITIQUEST is as you know, that CRITIQUEST is the platform of Alchem, CME platform of the Alchem, where we continuously doing a lot of medical education program. So this is the first anesthesia series under CRITIQUEST. On the occasion of World Anesthesia Day, which was there on 16th yesterday, so we thought we will arrange a webinar in remembrance of World Anesthesia Day and correlate with some subject which is related to the anesthetist and intensivist. So I will not take time because there's a lot of academic inputs to be given by our chairperson, moderator, Dr. Mehta, then our speaker, Dr. Malviya, Dr. Vibhukal Das, panelist, Dr. Jirpe, Dr. Ranveer Tyagi, and Dr. TNS. So with that, I will hand over the forum to Dr. Dattat Power, who is our senior medical advisor in Alchem. Dr. Datta, I request you to introduce our chairperson and then take it forward. Thank you.
Thank you, Sandeep. So, good evening, all. Myself, Dr. Datta Pawar. And on the occasion of World Anesthesia Day, I would like to welcome all the anesthetists, intensivists, and clinicians to this national webinar on pain management, that is CRITIQUEST. And we are privileged to have Dr. Yatin Mehta as chairperson, and Dr. Deepak Malviya and Dr. Vibhu Kalyani Das as speakers for this event. And we also have Dr. Ranveer Tyagi, Dr. Kapil Jirpe, Dr. Thirugnana Sambandam as esteemed panelists to discuss the pain management in detail. So it gives me immense pleasure to introduce Dr. Yatin Mehta as a renowned anesthesiologist in the country. He did the undergraduation from UCMS and MD from EMS, and he then trained in Nottingham, Denmark, Sweden, and he was also awarded with FRCA, FMS, and FISCM. So after he completing his specialized trainings, he started practicing cardiac anesthesia at Scott Heart Institute, and was one of the pioneers in cardiac anesthesia and critical care. So he was president of Indian Association of Cardiovascular Thoracic Anesthesiologists. He is also president of Indian Society of Critical Care Medicine, the Simulation Society of India, and the Research Society of Anesthesia and Clinical Pharmacology. He is the founder of editor of Annals of Critical Cardiac Anesthesia. He has edited textbook on critical care, also atlas on critical care, and has more than 270 published articles in peer-reviewed national and international journals, and above 45 chapters in the book. So now I request Dr. Mehta to address this session. Thank you, sir. Over to you, sir.
Thank you, Dr. Pawar. Thank you, Sandeep and Alchem for organizing this CRITIQUEST. Timing is perfect. World Anesthesia Day was yesterday, and pain is the main thing which we need to concentrate on. So it's a pleasure to introduce Dr. Deepak Malviya, a dear friend of mine. Besides that, he earlier he was a professor at Gorakhpur Medical College, and now he was director, and now is the head of the Department of Critical Care and Anesthesia at RML, which is a very famous hospital of Lucknow. So he's going to talk about the role of analgesia in critical care, and this is relatively a more ignored topic among the intensivists. So it's absolutely appropriate that he talks about it. So Dr. Malviya, please.
Thank you, Dr. Mehta, for wonderful introduction. And really, I'm proud to have a friend like you. And the topic you have given to me by the Alchem company is the pain management in critical care, which is almost really a neglected one. There's no doubt about it. Why is not going? Just a minute, slides are problem. This is my institute where we work.
Sir,
Incidence of pain in intensive care units 50% at
Dr.
best.
Malviya, the slides are, you have to share the slides. Have you,
Share the slide. Just a minute. You get it?
no.
No, sir.
आप सर नीचे देखिए ग्रीन कलर का लिखा है शेयर स्क्रीन. अब नीचे देखिए एक बार है शेयर स्क्रीन लिखा है.
Why is not sharing? Which
Yes,
side?
share
Right side or
screen.
left side?
नहीं नहीं आप एकदम बीच में सेंटर में देखिए Q&A, chat and share screen लिखा है. Share screen.
No, no, I'm not getting.
You can just first press escape, and then you can see the panel wherein
Huh? Yes.
Click on the Zoom. Click on the Zoom icon, sir.
share screen. First of all, you have to escape. Because sometimes
Is escape.
No, sir. Click
now
on the
you can-
Zoom icon. Click on the Zoom icon, sir.
Zoom icon. Yes. I click it.
Yes. Can you come to the Zoom, sir?
Share screen.
Dr. Mehta, could you get it?
No.
No, we are not.
What happened? Sorry for the trouble. A Zoom
Sir,
icon.
can you send a mail? Can you mail it? Some mail ID.
These slides,
Yeah.
I can mail it. What is the mail ID?
Yes, sir. Sir, we'll call you. We'll start with Dr. Bibu Kalyanidas.
Why you start with the Bubu Kalyan?
Yes.
I'm taking.
Yes, sir. We'll call you, sir. We'll call.
Okay.
Hello.
Mehta sir, with your permission, we are starting with Dr. Das, and then we will come back to Dr. Malviya.
Hello.
Yeah.
She is one of the senior most anesthesiologists in Kolkata. She is Director Academics at Institute of Neurosciences, Kolkata, Director of Neuroanesthesia, Neuro ICU and Pain Clinic there. And she is one of the landmarks of anesthesia in Calcutta. That's all I can say. So, ma'am, please go ahead with your address.
So, hello everybody. Good evening and belated happy Anesthesia Day. Hello, can you hear me?
Yeah, ma'am.
So, I'm very nice to see you all, and I have been asked to say some background history of this World Anesthesia Day. World Anesthesia Day. It is known as Ether Day also. In some countries they also call it National Anesthesia Day, and it is celebrated on the 16th of October every year across the country, actually across the world, and it commemorates the first successful demonstration of ether anesthesia by William Thomas Green Morton on 16th of October 1846 at the Mass General Hospital, Boston, in US. So Morton is considered as the father of modern anesthesia. So on this day, we pay tribute to the pioneers who have contributed to the progress of anesthesia, what we are today. And this is the pre-ether area. You can see that the patient is very brutally, it is a butchering of, it's not surgery, it is butchery. So you can see here. Next, please. And this is the Ether Day celebration, the first demonstration of ether as an anesthetic agent by William Green Morton. And the surgeon was J.C. Warren, and the patient was Gilbert Abbott, who had a tumor in the neck just below the jaw. And it was removed by Warren under anesthesia given by Morton. Next, please. So this is a simple equipment of Morton. Oh my God. Morton, where he gave anesthesia. It is like an open drop technique. And after anesthetizing, Morton said that, sir, your patient is ready for surgery. And after completion of surgery, the patient was asked whether he had any pain or not. And he said, no, I didn't have any pain. Only I had a scratch-like sensation there. Then the surgeon, Dr. Colin Warren, he in a loud voice said, gentlemen, this is no humbug. Next, please. And after 1 month, ether was used in other cities of United States and in Great Britain. And you cannot believe that within 5 months of this demonstration, ether was used in India, in Calcutta Medical College, under the supervision of Dr. O. Soani. There he is the surgeon, and ether was used in India just after 5 months. As we all know that ether was synthesized by Valerius Cordus long before this demonstration, that is in 1540. And he was used to call it as, it was known as sweet oil of vitriol. And the word anesthesia was coined by Oliver Wendell Holmes. And in 1846, he requested after the successful demonstration of Morton, he requested Morton to give this state of produced by ether after ether delivery, and if this state should be called as anesthesia, because it means insensibility to object of touch. Next, please. And this is the ether dome in memory of that event, and also William Green Morton. Next, please. Morton was born on 9th August 1819 in Charlton, Massachusetts. Studied in Baltimore College of Dental School. He was interested in medicine, but because of paucity of fund, he joined the dental school and in the Harvard Medical School. He was always innovative and very enthusiastic to have something to be done. So on 13th of September, Morton experimented ether for a painless tooth extraction, and the procedure was successful. So just over a fortnight, he was invited to give this public demonstration. And this is the monument of Charlton, his birthplace. Next, please. And this is the tomb of Morton. This is erected by citizens of Boston over Morton's over the tomb of Morton. And hello. Here very kindly it was inscribed by Dr. Henry J. Bigelow, the famous surgeon, and who also witnessed that demonstration. So he wrote that William T.G. Morton, inventor and revealer of anesthesia inhalation, before whom at all time surgery was agony, by whom pain in surgery was averted and annulled, and since whom science has control of pain. Next, please. So some information about the evolution of anesthesia in India. In ancient India, 600 BC, Susrut, in his Susrut Samhita, he mentioned that he used wine and incense of cannabis for anesthesia. He called Sammohini for the induction and Sanjeevani for the recovery from anesthesia. Next, please. And Raja Bhoj was operated by Sammohini and Sanjeevani for a brain tumor or something, brain lesion. So in the pre-ether area in India, we used to use opium, wine, Indian hemp, cannabis, and of course tying up the patient. And ether, as I have already mentioned, chloroform also, first used by Simpson in Edinburgh in 15th of November 1847, and 2 months after it was used in India on 12th of January in 1848. Next, please. Next, please. The first, some informations. First Indian woman anesthetist, perhaps the first one in the world, is Rupabai Fardunji, who was involved in the Hyderabad Commission study under Edward Louis. And there are many persons, eminent persons, MC Ganguly from Calcutta, Jyoti Prasad Jodhpur, they produced well-documented paper on ether observation. And they said that open ether is practical even in hot weather and with a less cost. Alenjana Combi, he is in the Presidency General Hospital of Kolkata. Now it is Seth Shukla Karnani Hospital, SSKM Hospital, the PG hospital. He used hypodermic morphine in 1880 for smoother course of chloroform anesthesia, the first documented report of pre-medication in the world. Next, please.
Hello. Deepak Maleji.
Coming to anesthesia machines, on the 22nd of January 1935, the first Boyle's apparatus was arrived in Calcutta by sea. The first oxygen plants were installed in Calcutta in 1935, nitrous oxide in 1962. First indigenous Boyle's F rolled out from IOL in 1950 with imported parts, and in 56 it was entirely manufactured in India. During the first Indo-Pak War, the portable Boyle was developed as well as the air trial in apparatus. Next, please. Some interesting facts. As you know, that Mahatma Gandhi was operated on 12 January 1925 for an emergency appendectomy at Pune. He was given open drop chloroform, and a significant event occurred, like electricity failed, the battery exhausted from the torch, and the surgeon Colonel Maddock completed the surgery with the help of kerosene lamp. Can you imagine? It is in 1925, not very far. So next, please. Next, please. But 20th century, they had many global growth of anesthesia, be it in intubation and airway advances, anesthesia equipment, monitoring devices, drug advances, local anesthetics and their delivery system, anesthesia intensive care, pain management, palliative care, and organization of specialties. Next, please. So after 174 years, where do we stand now? We stand now from ether to desflurane, from nitrous oxide to xenon, from barbiturates to propofol, midazolam, dexmedetomidine, from curare to sugammadex, cisatracurium, from opium to remifentanil, and from Boyle's machine to EEG, bispectral index guided anesthesia delivery system, computerized drug delivery system, radio frequency generator, intrathecal drug delivery, spinal cord stimulator for pain management. Next, please. From Bart's ventilator to sophisticated ventilators with monitoring facility and with the gas monitoring also. From stethoscope and sphygmomanometer, now esophageal stethoscope, monitoring of various organs from brain to kidney, everything can be monitored, and involvement of the EEG system, the MEP, neuromuscular monitoring, neuroelectrophysiological monitoring, SpO2, IATCO2 is always there, and brain tissue oxygen monitoring, all these devices, intracranial pressure monitoring, everything. Airway devices from red rubber tube, we have many supraglottic airways devices and all types of tubes. From Macintosh laryngoscope, now we have video laryngoscope. From blind nasal technique, we now have endoscopic techniques. And from blind techniques to go for any injections for the root blocks, the nerve blocks, the lines, the venous arterial lines, we can have USG guided techniques now. And computerized analgesic and other drug infusion devices. Next, please. Next, please. These are the modern ventilators, PCA pumps, anesthesia machines we have now. So anesthesia today have advanced monitoring. For that, we have safer anesthetic drugs also, better techniques, better appliances, so and better understanding of the issues related to pain and consciousness. So no patient is too ill for us now, too young for us now, too old for us now to undergo any surgical intervention. We extend monitored anesthesia care to all of them. And now asleep, awake, asleep technique, awake and anesthesia, and minimum infusion anesthesia. All these things are going on. We have also robotic anesthesia in some places now. Anesthesia information management system is now in many sophisticated centers. Next, please. So now the anesthetist's role today is multitasking. We are not confined to the operation theater now. We are also involved in critical care. We are involved in emergency medicine, in the pain management system, in the palliative care, and also in the code blue team, in the brainstem death team, everywhere. And of course, in remote location procedures, we are there. Next, please. So this evolution from 2000 BC to, if you go to 2020, we are now here. Next, please. But we owe the pain-free and safe surgeries to those early pioneers who took the initial daring step, often at the immense personal cost. Morton perhaps was the inventor, but he was certainly the revealer. Modern medicine will always remain grateful to Morton and other unsung heroes who gave us the boon of anesthesia. Next, please. So the theme of this World Anesthesia Day 2020 has been said very rightly in this period of COVID-19 pandemic, that occupational well-being of anesthetists. If the anesthetist is mentally, physically well, then the patient outcome will be well. Thank you very much.
Thank you, Professor Das. Excellent overview of where we have come from and where we are going. I think covers the full spectrum. I remember many years back, I think Dr. Zirpe was with me in Boston. We had gone for a ID conference, and I went to see this ether dome, and the place was locked. But I managed to pull some strings and get some neurology residents to smuggle me in. I said, I can't come to Boston and not visit this shrine. So thank you very much for the overview. Now, is Dr. Malviya ready with this presentation? Sandeep?
Yeah, Dr. Malviya. Dr. Malviya is there?
Yes, yeah. I'm here.
Yeah. Your presentation is in the screen, sir. You can start.
Okay. Yes. Okay. Dr. Mehta, this is a pain management in critical care, which is really a challenging topic. This is almost underestimated, and incidences we can say is almost a 50% at test and 80% during procedure. This is the pain management scenario. And what are the types of the pain? As one because of underlying etiology, anatomical location, temporal intensity, and underlying etiology most of the time is a nociceptive, inflammatory, neuropathic, or psychogenic pain. Anatomical location is a somatic or visceral. What we are going to talk about, what is the definition of pain, why there is pain management required in critically ill patient, how to assess the pain who is on ventilator, objectives of the pain management, pharmacotherapy of pain in brief, and what is the message we are going to. The pain is the ISP state is an unpleasant sensory or emotional experience that is associated with tissue damage or in terms of tissue damage. Yeah, sometimes we find is delirium, which is also defined as acute confusional state with attention deficit disorder, thinking, and fluctuating course. What are the causes of pain? If you go on the causes, this is underlying illness or injury. This is physiological changes which accompany the pain, or recent surgical procedure or invasive procedure which can lead to development of chronic pain. Noxious stimuli in the critical care unit, like tracheal intubation, nasogastric tube, mechanical ventilation, routine nursing care such as repositioning, they are all cause of the pain. Post-operative pain, this is the most feared problem among the patient and inadequately treated in 50% of surgical procedures. More than 80% of patients experience post-operative pain and 71% experience moderate to severe pain. 75% believe it is necessary to feel pain following surgery. 8% postpone surgery because of the concern associated regarding pain. This is still undermanaged post-operative pain till date, although it's quite better in the last 20 years, 2 decades. We are managing, but still is undermanaged. And that's what is the need of the pain management. Why this is so much important? This is incidence of significant pain is still 50% or higher in both medical and surgical ICU patients. A study of Chan et al. Reported 65.4% of patients had delayed discharge because of the poor pain management. More than 80% of the ICU discharge patients had painful memories and discomfort associated with the endotracheal tube. 38% of remember pain as their worst intensive care memory even 6 months later. 70% of patients recollect experiencing severe pain 6 months after discharge. 18% were at the risk of the development of post-traumatic stress disorder. One of the film actors, after tracheostomy suction, he described the pain of suction just like taking punch biopsy from oral mucosa, just like that. Inadequate management, there is a need to assess the pain. How to assess this? This ISP state, this defines the inability to communicate verbally does not negate the possibility that individual experiencing pain and it is in the need of the appropriate pain relieving management. Pain assessment includes location, characteristic, severity, onset, progression, duration, quality, radiation, elevating and exacerbating factor, and effect of previous therapies. Examples of pain scale, what we assess in the critical care unit. This is either in adult as a verbal numeric scale, visual analog scale, defense or veteran pain. But we do it with patient who most of the patient cannot communicate. The most common scale is we do the behavioral pain scale or critical care observation tool. We do it. And objectives of the pain management coming to minimize severity of the pain, that is post-surgical pain, continuous monitoring of efficacy of the drugs we are giving, prevention of the development of chronic pain syndrome, control of anxiety agitation, particularly intubated patient, facility rapidly recover and return into full function, improve quality of life of the patient, and reduce mortality and ICU stay. Modalities of pain management that includes the patient control anesthesia is not practical in most of the critically ill patient. Nurses control anesthesia one option, and regional blocks or neoaxial block or multimodal anesthesia. Pharmaceutical aspects of the pain relief, as you all know about the WHO analgesic ladder, Then step 1 is the non-opioid, step 2 is the opioid, and step 3 is opioid with the moderate to severe pain. Commonly used pharmacological methods we use is opioids, tramadol, morphine, and fentanyl, or allied paracetamol, NSAIDs, ketorolac, diclofenac, aceclofenac, antispasmodic drug is the visceral pain is hyoscine, or adjuvant to is antidepressant and anticonvulsant. Topical analgesics, that is muscle relaxant, anti-anxiety medication, and regional blocks. Analgesic site of action. This is NSAIDs is a noxosceptor to transduction, local anesthetic transduction to transmission, opiates and alpha 2 agonist is transmission to modulation, and general anesthetic and opiates modulation to reception. Opiates, coming to the opiates, it is naturally occurring alkaloid and decreases the pain perception, increases the pain threshold, used for moderate to severe pain, and available to administer by various routes, especially opioid selection guided by intensity and duration of pain, tolerance and safety, and short acting opioids like remifentanil for acute pain. Adverse effects include CNS depression, respiratory depression, sedation, histamine release, especially the morphine, stimulates chemoreceptor zone, centers and area postima, and causes vomiting, abuse potential tolerance, dependence, and opioid-induced constipation. Commonly used preparation is IV or in the patch form, the morphine, fentanyl, or remifentanil, and most common adverse effect is with the remifentanil is bradycardia and hypotension, while muscle rigidity is a problem with the fentanyl and accumulation and hepatic impairment. Another most common drug today is we are using most of the patients in critically ill patient is paracetamol. This is by inhibition of prostaglandin synthesis in the central nervous system, and doses is 500 to 1 gram every 4 to 6 hourly, maximum 2.5 to 4 gram in 24 hours. Route it can be oral or intravenous. Effective as both an analgesic and antipyretic, used for mild pain, score from 1 to 3, and risk is hepatotoxicity again and contraindication in the patient with liver diseases. NSAIDs is most commonly prescribed analgesics, act by inhibiting COX-A1 to COX-2 enzymes, result in decreased production of prostaglandins from arachidonic acid, and used as analgesic, antipyretic, anti-inflammatory action, and effective for bone and inflammatory pain, and commonly used in diclofenac, ketorolac. Adverse effect of so many of the NSAIDs are this gastrointestinal, which is very common, especially in critically ill patients, as the abdominal pain, nausea, vomiting, and ulcer and bleeding. And the another is the renal insufficiency, renal failure, and hyperkalemia is protein and proteinuria, especially in critically ill patients. Antispasmodic, hyoscine, butyl, and the dose is 20 milligram intravenously. Side effects: sleepiness, vision changes, allergies, and triggering of glaucoma. Adjuvant drug we are using is not typically pain mediation, but may relieve the discomfort, potentiate the effect of pain medication, and reduces the side effect burden. At this, most of drugs used is antidepressant, anticonvulsant, topical analgesic like muscle relaxant, etc. Antiepileptic, the common use is gabapentin, pregabalin, or carbamazepine. Antidepressant use is most common use is duloxetine or amitriptyline. Regional anesthesia is the one option in critical ill. This is cost effective and provide long and the good quality anesthesia. Fewer side effects. As Madam told already, with the advent of the ultrasound used in the critical ill patient and the for the blocks, this is one of the option in critical ill patient. Central and peripheral blocks and can be done by neuro ultrasound guided neurostimulation. Plexus and nerve block for management of localized pain. Used drugs are usually lignocaine, bupropion, and ropivacaine. We prefer ropivacaine, of course, this is purely blockade. Concentration is again those 0.125 to 0.375%, and duration is almost 6 to 12 hours. And success rate is with ultrasound guide is almost more than 90%. and side effects are very less. And reasons, what is the reasons for the poor management of pain, especially in ICU? Is this BQ? Is main reason is failure to acknowledge the pain and failure to assess the initial pain and failure of the to have adequate pain management guidelines, failure to document pain and failure to access treatment adequacy, failure to meet patient expectation, concern regarding opioid reduction and abuse, fear of opioid side effect. Coming to at the end is the take-home messages. Critically ill patient may experience pain due to underlying illness or injury. Maintenance of acceptable individualization level of the comfort requires routine frequent pain assessment. Different pharmaceutical options available for pain management and we must use it. Multimodal anesthesia can lower the opioid requirement. Thank you very much.
Over to Dr. Mehta. Sir, your mic is, you have to unmute your mic, sir.
Sir.
Hello everyone. It's Dr. Hemant. I think in interest of the time, I think Dr. Yatin Mehta has got disconnected due to technical issues.
Okay,
Sir,
can you hear me now?
yes, Dr. Mehta, we
Yes.
can hear you.
Okay, thanks a lot, Dr. Malviya. Excellent
Thank you.
overview of pain management. And
Thank you.
I think we'll reserve the question answer at the end because we have a panel discussion also. So I think we have a presentation from Alchem. Is that correct? We have a presentation, no?
So, hello.
Role of IV paracetamol. You have a presentation, no?
Yes, sir. Yes, sir.
Please do that.
Now I request Dr. Hemant to give his presentation on pain management, role of IV paracetamol in pain management. Thank you. Over to you, Hemant.
First of all, respected faculties, Dr. Mehta, Dr. Malviya, Dr. Tiru Sambandam, Dr. Bibu Kalyanidas, Dr. Tyagi, Dr. Zirpe, and my all the visitors and the audience who are sitting and patiently listening for this session. Uh, wish you all a belated World Anesthesia Day. Hope you had a good day yesterday. So continuing with our talk for pain management, Dr. Malviya has done justice to this topic, and somewhere I will like to highlight the role of paracetamol in it. So as Sir has already highlighted this pain analgesic ladder by WHO, we find that non-opioids are at the base of that, and there are wide variety of molecules which are available in this category. But do we really have an ideal analgesic to satisfy both the efficacy as well as safety of this area? We know there are many efficacious molecules, but we saw that there are safety concerns with other molecules where irrespective of the class, there are some concerns, drug interactions, some complications, organotoxicity, etc. So definitely there is a need of a molecule uh, in this current sector, because somewhere the trend now is moving towards the non-narcotic sector, because we know the opioids, maybe the synthetic ones or the natural ones, have this side effects of respiratory depression, nausea, vomiting, And if there is hypothesis that even a single dose can have that abuse potential. So even if we move towards the NSAIDs category, there are always the deleterious effects on the hematological parameters as well as ulcers. There is severe risk, wound healing, especially in orthopedic surgeries, and hence there is a need of the hour that we see a molecule which is having a comparable efficacy and definitely provides a superior safety when we compare with the NSAIDs and opioids. And I think the safer option which points out and which has gained the confidence over the ages is paracetamol due to its safety across all the ages, right from the neonates to the geriatric population, and not being associated with any side effects, which are all found out with the other comparator drugs. So not going into deep, just mentioning that this drug has found its place as the first line of agent as an analgesic in mild to moderate pain, and there is a boon of being an antipyretic agent also due to action in the hypothalamus. And the analgesic effect basically come out from by blocking of the COX enzyme and blocking the central prostaglandin release, which leads to the pain. So why IV paracetamol? The answer lies in the PKPD, that is pharmacokinetics and pharmacodynamics. Pharmacokinetics is very much favorable, due to which it doesn't find any variability in any types of surgery or chemotherapy. No variability between the patients. The Cmax, that is the concentration maximum after 1 gram infusion, is achieved in a time span of 15 minutes. So we can have an onset of action within 15 to 20 minutes with a plasma half-life of 2.7 hours. Now we know that the molecule is excreted in urine and is metabolized in the liver. But sometimes the minor pathway to the CYP40 might lead to accumulation of its toxic metabolite NAPQI, which can be resolved by the an injection NAC, that is N-acetylcysteine. But that might not be always possible in renally compromised patient, and the half-life might be extended. So the dosing interval needs to be extended in such patients. Moving on to the pharmacodynamics, the effect, that is analgesic effect, starts appearing within 5 to 10 minutes of the administration, and the peak analgesic effect occurs almost after 1 hour, and it lasts for 4 to 6 hours. Again, I would say why IV paracetamol when we have tablet or the rectal formulations. The answer lies in the bioavailability and the variability. There is less amount of variability with IV paracetamol, rapid achievement of the maximum concentration, and that's why IV paracetamol will offer a better care when it comes to the critically ill patient. And fever reduction, of course, occurs within 30 minutes and effect lasting for 6 hours. Now, this slide provides us the dosing guidelines for paracetamol. I would like to focus on the a weight that is 50 kg. Above 50 kg, only thing to look out for is hepatotoxicity if the liver is compromised. If below 50 kg, please go by the dosing guidelines of 15 milligram per kg with a daily dose not exceeding of 4 grams. As I said, in case of renal compromised patient, the dosing interval should be 6 hours, and the dosing administration can, once the drip is started, it should be finished in 15 minutes, over 15 minutes. Moving on to some clinical evidences of paracetamol, it has definitely shown its efficacy over placebo with a low incidence of adverse effects as well as drug interactions. Uh, um, Again, the studies have proven time and again that IV paracetamol is effective over the orally administered drugs. But I would like to bring it to the attention that we need to calculate even the orally administered paracetamol for looking at the total toxic dose. That is, if you are administering 3 milligram IV, then please consider the orally administered paracetamol also, if any. There was a Cochrane review which brought out the findings from 75 studies, which included 7,200 patients, mentioning a high quality evidence of single dose IV paracetamol providing an effective analgesia for around 4 hours. Now, this is about a surgery from head and neck cancer where the second arm was provided fentanyl and a preemptive paracetamol. I think this is a new thing which is being tried with paracetamol, IV paracetamol showing a good results in preemptive analgesia, both for total intravenous as well as regional blocks. So it has shown a good efficacy when compared to fentanyl also in terms of adverse effects as well. So when we compare it with NSAIDs also, the analgesic effect in both in major as well as minor surgery with respect to even cardiac surgery has shown a good analgesic outcome, non-significant, that is similar to that of an NSAID. When used in combinations, it definitely has reduced the opioid analgesic requirement, and the outcomes were similar when we compared both with paracetamol or with NSAID, that is the combination when it's compared. Now, head-on comparison with fentanyl in mild to moderate pain, definitely the study shows that the VAS scores are same in both the arms, where paracetamol has proven its safety and efficacy in ICU patients with mild to moderate severity. Now, the opioid sparing effect, yes, definitely this should be a concern when the patients are treated with moderate to severe pain. And the trend is towards using multimodal analgesia. And with this, paracetamol has definitely shown a significant decrease in the requirement of opioid, and hence we can avoid the unwanted effects of the opioid adverse effects. This is from the orthopedic surgery, where IV paracetamol has reduced the morphine consumption with a good effect. And definitely due to this, paracetamol has achieved recommendations for management of acute pain in mild to moderate patients as well as in renally compromised patients. So that was for the molecule. But what new does Alchem bring to the table is the same molecule, but same molecule, same composition, same pharmacological class, and same indication. What's different? So the problem lies over in the plasticizers, which are used basically for the packing. These plasticizers, mainly focusing towards the PVC or the diethyl hexyl thiolate, is used commonly as softeners. Now these are toxic and might leach into your product, that is paracetamol, and cause damage to the patient. So there are papers highlighting the toxic effects of this DHP, and due to which we should move towards an environmental patient friendly packing, uh, that is a flexi bag, which provides a self collapsible flexible option, low weight, environmental friendly. What advantages it offers to the doctor is ready to administer packing. Aseptic precautions are maintained by its closed infusion system, and hence it's easy to handle, easy to store, and environmental friendly. So not taking much time, the take home message, what I feel should be, NSAIDs, opioids are definitely there for their efficacy, but a safer option is paracetamol when it comes to mild to moderate category. Clinical studies do prove the efficacy of paracetamol, and now that the FlexiBag offers advantages of non-PVC, DHP free packaging along with closed infusion system. Thank you. Over to Dr. Mehta.
Thank you, Dr. Hemant, for a very nice overview of paracetamol. I think what now we'll do is that we'll proceed with the panel discussion, and I will address some of the questions, my questions, to the panelists who have been patiently listening to the two speakers and three speakers who have not participated as yet. So let me introduce you quickly the three other panelists besides the speakers. Dr. Kapil Zirpe really needs no introduction. He is a past president of Indian Society of Critical Care Medicine and is the secretary of Indian Sepsis Forum of India. He is also he's been one of the most active ISSM presidents, and he also is the director and HOD of the neurocritical care. He's also the president of the Neurocritical Care Society. So he's a very active academician and a clinician. It's a pleasure to have you. Then I have Dr. Ranveer Tyagi. He's the vice president of Indian Society of Critical Care Medicine and director Anesthesia and Critical Care at Synergy Plus Hospital, Agra, and very active intensivist from Agra. Very active, not only in ISCCM, but also in ISC. He's hosted annual conferences of both of these and very fantastic conferences in Agra. And then we have Dr. TLS, is Chief Anesthesiologist, Apollo Cosmetic Surgery, Chennai, Plastic Surgery, Chennai. So thank you all of you for coming. And the other two are Dr. Das and Professor Malviya. So I'll address my first question to Dr. Zirpe. So what is the real world experience of use of IV paracetamol in renally and hepatic compromised patients? Dr. Zirpe.
Sir, good evening and good evening to everyone. Thanks for inviting me as a panelist. And let me tell you, initially when paracetamol was not available in India in 2004, 2005, I used to heard from my colleague who was from the England. They were, at that time, the Europe were very familiar with using the paracetamol in 1 gram as an analgesic. And then after the launch in, I think 2008 or 2010, we have launch of the, or availability of the injectable paracetamol. It becomes suddenly so widened. It's like a routine analgesic we prescribe in critical care because we have lot many patients who need the good analgesics, which is a renal safe and which has the less toxicity. Coming back to your question, sir, regarding the renal and hepatic. Let me tell you, the paracetamol is, though it is excreted in the renal, it is safe as per the our practice we are prescribing. But recently, my opinion is slightly changed recently when I came across the systemic review, and it was a good systemic review of the almost 13,000 patients in 2020. It was mentioned, and they have said that you have to be careful in terms of if the patient on the verge of the developing the renal injury, or if the patient is compromised. Generally, our critical care patients are on inotropes, they are hypovolemic, they are having the sepsis, so they are already on the verge of the renal injury. And on the top of that, if you are not careful with the paracetamol dosing, the here issue comes with the dosing. Dosing should not exceed the routine dosing should not be exceed 4.5 gram. That one everyone should understand. But in critical ill patient, I believe that it should not over more than the 3 gram might be your landed, and that systemic review suggests that there are the chances of the developing renal injuries are very high if the patient is on the paracetamol. So be careful if you are prescribing the paracetamol 1 gram 4 hourly, 6 hourly in a critical ill patients. You should be more careful. You can make the combinations of the different analgesics where we can keep your patient calm and quiet and the pain-free. Secondly, regarding the hepatic involvement, though it is metabolized in the liver, generally it is safe in an acute liver disease. It doesn't cause the major trauma in a it is very safe in a chronic liver disease. You can go up to the 3 gram. But in acute liver disease, you have to be careful while using the paracetamol. So you have to have a complete overview of your patient, the clinical condition of the patient, the need of the analgesic, and don't just rely on the paracetamol alone in such patients. Makes a combination and try and have control over your dosing. That's what my take on using paracetamol in renal as well as the hepatic involvement.
I think that is very nicely covered in both the situations. What is your opinion about maintaining the sterility and possibility of contamination during administration?
Sir, such question should not be asked to the intensivists. We are most concerned. See, what we are concerned in the ICU is the infection. Unfortunately, we are coming across the infection from everywhere. And during this COVID, our staff is compromised. Our healthcare system is compromised. We do not have the adequate number of the staff. We do not have the adequate experienced doctors, sisters. And in such situation, I believe in the infection control practices have a lot of impact on the day-to-day practice. And in this situation, and forget about the COVID, and even in the pre-COVID and the post-COVID, what is my first priority in my ICU is the infection control. So whichever the things, whether it is your IV solutions, whether your injections, whether your different drug deliveries, your instrument, machines, I'm most concerned about the infection. And it makes a lot of difference to me. I would like to adopt such systems which will reduce the handling, such systems which will help me for the infection control, because I'm not bothered about the cost. I'm bothered about the one extra day in my ICU, patient's day in ICU. So if it is going to help, Yes, of course, it matters a lot. So such a closed systems, I always welcome, whether it is a paracetamol, whether it is related to the antibiotic, or whether it is in any drug delivery concern. It is a prime priority and important thing in a critical care setting, sir.
See, bloodstream infection, we all are dreading it, particularly in the COVID times with immunocompromised patients. So I think anywhere closed system would be preferable in this sort of situation. There was a
Sir,
paper by Victor Rosenthal from Argentina, and in Buenos Aires, he demonstrated that between closed system and open system in two ICUs, there was a 3 times difference in BSI. So I think
yeah, and generally, sir, to add one, we generally the excuses are given that the cost factor. I always say that the cost factor, I don't look at the single cost factor of the antibiotic or my IV set. I look at the number of stays in ICU. Even if my number of days of the patients in ICU reduced by 1 or 2 days, that covers the life risk as well as that covers the cost of the patient. I never convince my patient that the cost is high, so we should not use. I always convince that which are the added advantage with this particular drug or this system or the cost, which will help them to reduce the cost, overall cost of the management as well as the risk to the life. So I always prefer such systems which will help me. And unfortunately, we cannot put an extra burden on our existing compromised system. So again, these systems will help us for the giving some relief to my staff about the medication preparation and hand washing and everything.
okay.
That's what
Thank you, Dr. I'll bring in Dr. Ranveer Tyagi. So Ranveer, how do you and what sort of scenario you'll use paracetamol? Mild pain, moderate pain, severe pain?
Paracetamol, as Dr. Hemant already described most of the things in their lectures. This is an excellent drug, or you can use even in the pregnant women, children, any age, and very safe drug. So this for mild and moderate pain, we are using in the OT, in the ICU, or even in the ward, every place. No any side effect, even the respiratory depressant, sometimes contramal and opioid occur in the ward. So you can use safely without any risk in the patient. So paracetamol for mild to moderate is excellent drug. I think everyone is using in India. I think the number one drug people are using this paracetamol in the today in the pain management.
And how do you taper your analgesics?
For taper, sir, paracetamol taper when you need taper for tapering indication when no pain patient, just like pain coming for the knee replacement. When you replace knee replacement done after 4 or 5 days, you start tapering because the main root of the pain is resolved. And if the side effect is more, sometimes the main side effect is liver toxicity with aging. So then you start tapering. For tapering, you have to counsel the patient or give some alternative drug or some block, and you start tapering. The tapering problem with the opioid is very difficult when you want to start. So start tapering, 10% reduction dose bi-weekly or weekly, you can start with the tapering.
Yeah, also, I think when you're tapering from strong analgesic, severe pain, when it comes down after a couple of days of surgery, maybe that is the time to go through paracetamol, from narcotics to paracetamol.
Yeah.
That will be easy way. What about the role of adjuvants in analgesia?
Adjuvant is the good drug when used, when your primary analgesic drug are not working, then you add the adjuvant. Adjuvant not a primary analgesic. Sometimes they work as a primary, as a tricyclic antidepressant work in post-therapeutic neuralgia as a primary. But most of the time adjuvant is the secondary. You can add, like they add in the different situation. Like you add a muscle relaxant. When muscle is tense, then you add a muscle relaxant. You cannot relieve by the NSAID or opioid. You add a adjuvant analgesia, and anxiolytic sometimes, and some anticonvulsant, antidepressant. These are the different drugs you can do. For neuropathic pain, you can add anticonvulsant. So different adjuvants for different type of pain, neurologic pain, acute pain, like spasticity, or in stroke patient, you carry butyrolense type to injectable, and local anesthetic you can use as a adjuvant anesthesia or analgesic also.
Also, alpha 2 agonists have been used, no? That is chloridine and dexmedetomidine along with the. They also quite helpful.
Dexmedetomidine, people are using OT and ISU as a sedation as well as analgesic.
Also for weaning from ventilator, when the patient gets irritable, I use a lot of dexmedetomidine at that time.
Yeah.
Okay, thank you. Now, for Dr. TS, what about the role of closed system, infusion system? Part of it we have already covered. Dr. Sambandam.
Yes, sir. There is a very clear evidence that closed systems are far more superior than open infusion systems. And particularly when we deal with immunocompromised patients, pregnant patients, neonates, and people with elderly patients, wherein hospital-acquired infections are quite common. So closed systems are always beneficial, and there is adequate proof that when you use closed system, the incidence of infection rate comes from what it is going to be 10 to 3 per 1,000 when you use closed system. So I am for closed systems, but then the thing is 1 or 2 infusions if you use closed systems, and the rest probably, even if there is going to be a breach, even when you use say if you want to administer an antibiotic infusion and that comes and that particular antibiotic comes without a closed infusion system, then there is a breach, and then there is no point having only one. So it has to be a policy decision made from the administration that the entire system or entire infusion systems should be closed, and that is where the catch is.
And what about the environmental friendly packaging?
Oh yeah, they covered a lot about the PVC and then the DHEP. So these actually PVC emits lots of chlorine, and then that can even go into the food chain and then come back to us. DHEP is a softener. It's a flexibility producing agent. Otherwise, PVC is going to be hard and brittle. When you use these softeners, these are phthalate groups, and these are carcinogenic and mutagenic, and it is nephrotoxic even. So it is prudent that we avoid these kind of PVC which use these softeners. There are alternates which can be used, like polyethylene or polypropylene preparations are there. So those materials are preferably used instead. Maybe a little bit of a cost might be a factor in the initial days, but then I think there will be a switchover sooner or later. They are going to dump all these, and they have started to do that in other industries like food industry, packaging industry, and that particularly it has to come here into our medical industry too, because PVC is quite elaborately used in our industry, so that has to come down, and those softeners needs to go away. And regarding that, the hepatic impairment question that you asked, whether you use paracetamol, when we use paracetamol IV, the main important thing, the advantage of using paracetamol IV is it bypasses hepatic metabolism, and then that's where the hepatic toxicity is coming down. And preferably in a patient, there is a lot of difference between when you give it orally, the bioavailability, it has to go through the liver and glucuronidization happens, or oxidation is the one which produces more of a toxicity, and that bypasses. The IV paracetamol bypasses. Renal, yes, okay, you got to adjust the dose, but then in IV, if you are confining yourself to safe dosage limits, I think IV paracetamol will not be a problem when you have an hepatic impairment. At least not an end-stage liver disease or completely decompensated liver disease. Decompensated liver can still take paracetamol. But if you have other agents, you can avoid.
That's a very relevant point, what you said, yeah. Question for Dr. Professor Das. So what are the pros? Can you summarize the pros and cons of IV paracetamol? Professor Bibu Kalyani, is she there?
Yeah. What was the question?
Pros and cons of IV paracetamol.
pros and cons of IV paracetamol. As you know that I practice neuroanesthesia and neurocritical care. So pros and cons, as already discussed, you have to be very careful in renal and hepatic compromise patients. So, but we in the neuro case, in induction, I use till now we use fentanyl. And then after in the postoperative period, our patients are not very painful. Only the spinal surgery cases, they are very painful surgery. So in spinal cases, we can use paracetamol. The pros is that we can go for multimodal analgesia, and it is a safer drug than you cannot use the NSAIDs. NSAIDs, they are definitely, they will cause harm to the kidney, and they definitely will cause the coagulation disorders. So so these are the things, limitations of other drugs. So paracetamol is a bit safer drug in this respect, I can tell you. And the cons only the hepatic and renal compromised patients. Otherwise, there is no harm in using paracetamol. You can use in any route, you can use it, and there is no harm.
And how do you monitor the efficacy of analgesic?
The analgesia, actually the scales as in the I also run pain clinic, so it is chronic pain. In chronic pain, some of the cases I go for combination therapy, but my neuropathic pain, as Tyagi said, that the mainstay is the anticonvulsants, so gabapentin or pregabalin. Along with that, we can give paracetamol. Now paracetamol tramadol combination also I use in that cases. And the monitoring is visual analog scale and all these scales as we have. But in neuro cases, you cannot go for that. Only the parameters of cardiac parameters, the heart rate, the blood pressure, etc., you can go for that. So these are the things. And in the ICU, we actually don't use analgesics too much. Only for patients, spinal cases, I said that we go for NSAID in combination therapy, multimodal analgesics, some blocks and something we always go for that. But solitary paracetamol is not enough for this pain. The back pain, back surgery, instrumentation, you cannot go for that. And in intracranial surgery, we don't need any analgesia. Actually, we don't need any analgesia. And some patients, they get anticonvulsants if they had previously, and sometimes also they give also an anti-epileptics for some time in intracranial surgery.
Dr. Zirpe, would you like to add something for neurocritical care?
Yes, what Madam says is right. We never use it as a single agent in ICU. Generally, these patients are on many supports. We always use in a combination. And of course, we can assess the pain. What she is saying that because of the neuro patients, they are not in a state to give us information. But you can have the bedside scale where the sisters can judge day to day in 3 times or 4 times a day. What is the effect of that painkiller? And let me tell you, this analgesis plays a major role in a stroke patients and those, because they are not able to tell us, they are not able to express their pain. Most of the time there is a bony pain, most of the time there is a muscle pain, not necessarily it is related with the stroke. So definitely it plays a major role, but not as a single agent. Single agent, we need to think whether really that patient needs the analgesic. So yes, it has a role in ICUs and the critical care.
And possibly polytrauma, head injury with polytrauma.
Yeah, again,
they would require something.
Then, see, when you are we are coming back to the polytrauma, I need tramadol, I need paracetamol, I may need a Buehler patch, I may need the additional sometimes epidural analgesia. So it depends on the extent of the polytrauma. But never a single agent we use as a paracetamol as a painkiller. We always use it in a combination. Like if suppose there is chest trauma, there is ICD. It is not the bony pain. It is the muscle sprinting is there. So I would like to have a tramadol with paracetamol combination, which will work more as compared to the paracetamol or Dynapar alone, because it's not the only bone pain. So I need to say whether it is a patient needs analgesic or patient needs analgesic sedation or patient needs analgesic sedation and anxiolytic. So that according to that we have to choose whether patient needs oral or bolus or infusion or might be in a patient control analgesia. So accordingly we can decide our agents in ICUs.
Dr. Malviya,
Yes, sir.
how do you, the challenges which you face in the critical care for an analgesia? Summarize them in terms. Yeah.
This main the challenge is actually the assessment of the pain is a difficult choice. With the is this just on empirical ground or behavioral pain scale? Usually, patient on ventilator will do it, and this is most of the ICUs. This is under relief. So it requires the multimodal therapy. On one hand, the patient is compromised state with the various anatopes and the vasopressures. With ventilator, the pain is usually undertreated due to sepsis, the patient having liver compromise, hepatic dysfunction or renal dysfunction, and usually it is underestimated. So
Yeah, absolutely. Absolutely right.
So that require, and the safety is with the paracetamol. This is a wonderful drug, and of course, paracetamol is available for the last more than 50 years. Oral preparation. Unfortunately, the IV preparation came in last decade. This is unfortunate. Just to have this one, and we get paracetamol, which has a much more safety, a margin of safety, and multimodal analgesia, of course, so that we can reduce the toxicity of the combination of drug. We should go ahead, along with the neuroaxial blockade if the surgical patient is there.
See, unfortunately, more attention in the ICUs is paid to the other vital signs.
Other vital signs, not the pain. Yes,
and
sir.
sepsis
Right.
and urine output, rather than the actual.
Naturally pain.
Yes, anybody can. Please add.
Pain is a sixth vital sign.
So nowadays we are in neuro ICU. If you are the patient is on ventilator and you are using DEX, then it is no paracetamol. If you give, you can have pain relief in many patients.
Yes.
And in trauma patients, you must relieve the pain by multimodal analgesia, because in acute pain it will go to chronic pain afterwards. So you have to address to the acute pain very correctly with multimodal analgesia.
Sir, I will add into that. In ICU, I will be more concerned with the painkillers and the painless patients rather than along with the other signs. So every day we would like to see that our patients are smiling, sitting in chair comfortably, less restless. They are moving in bed comfortably. They are communicating. So for this, we need to be patient pain-free. And I always say that these are the things which give you the comfort to the patient, doctor, as well as the relatives. So pain is one of the prime important in critical care areas.
Absolutely. Yeah. Dr. Malviya, any comment on malingerers?
This is one of the very common problem, and this is it is very difficult to decide whether it's malingering or patient is having really a pain, and especially this is females coming from rural background in the especially northeast UP. This is the main problem. It's difficult to assess. If you have any idea how to assess and find it,
we had a few patients. You had a few patients who were used to analgesics, who were taking some, and they would malinger that they need.
And these patients usually require antidepressant, not analgesic, and then they come out.
I have one. Dr. Mohammed Ibrahim has asked a couple of questions. That what about allergic reaction? Has any of us can answer that? Allergic reaction to paracetamol? Well, I haven't seen any till now.
Fortunately, I never came across.
No.
I also never seen any allergic rash with the paracetamol till date.
And one more question he has. Yeah, any dose adjustment for along with antivirals, for example, favipiravir.
Unless and until there is a liver involvement.
Yeah.
So generally we do the elaptives daily or alternate day. If the patient is on the remdesivir, we do daily. And if it's 3 times more, we have to stop that particular dose of the remdesivir and favipiravir. So if there is a high risk patient, those patients who are alcoholic or patients have the underlying liver disease, ideally we never prescribe the antivirals to these patients. So we have to keep monitoring. It's not that you should not prescribe the paracetamol. That is what my personal opinion.
Yeah. No, I agree with you. Some people stop it at 5 times the LFTs.
Yes,
But
yes.
3 times would be reasonable, I suppose. And one question is, how about using propofol MCT, LCT versus propofol LCT? Any experience, sir, for a pain due to propofol injection?
Ranveer?
Yeah. You can give using propofol. You can give a Gylo card before 1 milligram per kg body weight. You do not feel pain after giving the Gylo card, and then you give propofol. Better.
No, also MCT, LCT is supposed to be less painful than
Less painful, but still feel you sometimes the size of vein or where you put the intracat. They all depend on these conditions also.
Of course, MCT, LCT preparations are less painful.
Yeah.
And previously, initially we get the propofol. There was a company, I think somebody has made a propofol lignocaine combination also.
Yeah.
Initially, when it came in the market, and that was administered to relieve the pain, but it will not reduce the incidence of thrombophlebitis. It will equally there. The pain will be, of course, not there at the time of injection, but later on it will create problem. MCT, LCT preparation are definitely advantages.
So how to select drugs depending on intensity and type of pain? Any of you can comment.
Pardon? Intensity?
How do you select your drug depending on the severity of the pain?
Yeah, basically, we need to say why there is a pain. Whether it is a neurogenic pain, whether it is a bony pain, whether it is a muscular pain, or because of the inner. So we select the painkiller agent as per the which pain we are targeting. And in ICU, I told you that the pain is multifactorial. It cannot be because of the single factor. So we need to have combinations, and the combinations were decided by the patient's diagnosis, patient general condition on that day at that time, and the patient progress. Like for example, I say whether patient needs plain analgesics or patient needs analgesia plus anxiolytic, or patient need analgesia sedation plus so accordingly we'll choose. And even I am concerned with the drug delivery. It is not like that only IV drugs I will push or bolus drugs. Might be I will have a combination of the infusion with IV or infusion combination. So sometimes there is a fentanyl and the simtabadol will go, the fentanyl go, or sometimes there is a tramadol, paracetamol, and in additional doses, bevular patch will go. So it depends on what type of the pain you are targeting. It depends on what is the condition of the patient. It depends what urgency is to make the patient. See, if my patient is on ventilator, like what you said, the polytrauma patient is on ventilator, I need good analgesics to reduce the use of the sedation. So if I would like to reduce the use of the sedation, because my neurosurgeons would like to have patients in a more conscious state. And if they want a more conscious state, I need to have a less sedative and more potent analgesic. So I need to make a combination of good analgesia with less sedation. So these patients generally requires even no paralyzing agent, less sedation, and they will be managed by the painkiller. So this is where we have to have a good combination about the various analgesic agents and as per the indication.
Sir, Leslie spoken about the most fundamental part of multimodal analgesia is the point of care ultrasound guided peripheral nerve blocks. Whenever possible, whether it is in acute post-op setting or in an intensive care unit, wherever possible, whenever possible, please administer peripheral nerve block, preferably ultrasound guided, so that that is going to reduce most of your pain. and that is going to be the cornerstone of MMA. And one other thing is this paracetamol, though it is a simple analgesic, it has found a place in all the 3 steps of the ladder suggested by WHO, whether it is going to be stage 1, stage 2, or stage 3, whether alone or in combination of much more potent drugs. And also, when you use paracetamol in addition to other drugs, you are trying to tap the synergy by a complementary mode of action. So that is where you can reduce the dosage of either drug and then reduce the side effects too. So paracetamol, though it's a simple drug, it can be added or given in conjunction with other drugs to make the combination work as a potent combo.
See, in my opinion, IV paracetamol, at least for surgical pain, it remains the backbone of surgical pain, because that would be given, I mean, at least for the first couple of days after surgery, and then you can supplement it unless the patient is on PCA pump or something like that for very severe pain, because it is completely safe, not only in liver and hepatic, otherwise also there is no respiratory depression. You don't need to worry about.
So what will be the bolus dose that is given? What is the maximum dosage that can be given as a single bolus when you administer intraoperatively? Any experience like more than 1 gram?
No, generally we don't.
It suggested the 2 gram.
2 grams. 2 grams are supposed to be like giving a better benefit.
More potent and effective as compared to the 1 gram.
Yeah, and they say up to 3 grams, but 2 grams I feel is safer in patients who don't have any hepatic impairment or renal impairment. That's maybe to put it like that. It is better to give 2 grams to get the maximum.
There were the good papers of the 2 gram versus 1 gram, and they say that the 2 gram is more effective in initial control of the pain, and then you can maintain with the lesser doses. So initially, if you control that surge of the pain, like
I know, sir, but then this
absolute right.
Yeah.
The wonder.
I know the concept of preemptive analgesia comes into the play, but then literature does not support, or it has a lot of controversies regarding the effectiveness of preemptive analgesia. But still, a larger bolus dose helps, maybe to bring down the subsequent doses or need for that is your opioid-free analgesics therapy in total.
Agree, fully agree.
There's no role nowadays on preemptive analgesia. If you are going for a surgery and post-operative, then preemptive analgesia there is no role of preemptive analgesia. So after
it's a very controversial topic, madam. There are a lot of studies which approves, and then there are a lot which disapproves preemptive.
If you have preemptive device, you can monitor also, and what is the dose you can give, and you have a continuous infusion. Bolus we don't use actually. For continuous infusion in a PCA device, you can go for that. And sometimes if the patient needs, then you can give some bolus. And that is and multimodal analgesia is always preferable, because only paracetamol in a patient who has neurological pain, neuralgic pain. So you cannot go for only this one. It will not do any good. And in cases of patients having burning sensation and neuropathic component is there, so you can address both neuropathic and analgesic so these are the things. It is individualized. All the patients are individualized. You can go for a combined things, and then the peripheral nerve blocks also. USG guided you have in your ICU, you can go for USG guided blocks if needed. Along with that, some paracetamol. Paracetamol is now routinely used in the post-operative period, in the intraoperative period in our setup. It is used routinely. And along with that, we can add something. And then you monitor the patient for liver function, as Kapil said. You can go for liver function monitoring and all these things.
Do anybody use coxib still? And if so, in in which context that you use coxib? Maybe in orthopedics, or do you still use coxibs?
Yeah, in orthopedic they use, because I have personal experience when I had ankle avulsion and post-operative. When you use clutches, now your shoulders are generally, your shoulders and these muscles get severely this thing. So if you take the 60 milligram OD along with the good physiotherapy, that is a very, it is a wonderful drug. Believe me, it's a wonderful drug with the immediate effect on that. So I have very personal experience with that, and I'm very happy with that drug. But again, very particularly indication, not in ICU or not in critical care situation. What you said is the orthopedic. The orthopedic use still in a very regularly in their bony pains or muscular pains generally.
The thromboembolic events and the cardiovascular events that are possible quoted side effects of coxib.
But 60 milligram OD dose is not very high. They are dose related and the duration related. So 60 milligram, I don't think OD dose will harm anything about this thing. Only in high-risk patient, you have to be more careful.
Be more careful.
Yeah.
So I think we have covered almost all aspects of analgesia in intensive care, including the uses of paracetamol. So I'm just summarizing what we have basically discussed, that multimodal analgesia is better, sensitivity to patient's pain and looking for it, and titrating the adequate doses and adequate modality for a particular severity of pain is important. And paracetamol is a safe, IV paracetamol is a very safe drug, including in liver and hepatic dysfunction. And you can add stronger or better drugs for more severe pain. So with that note, I would like to thank all the participants and the panelists and the speakers for a very interesting evening. Nothing like the Saturday evening talking about analgesia. And I would hand over the mic to Sandeep.
Thank you very much for the excellent moderation.
And thank you, everyone.
Thank you, everybody.
Thank you.
Thank you.
Happy Navratra to all. Stay safe, stay healthy.
Same to you.
Would Alkem like to say something? Sandeep?
Yeah. So Sandeep, you are mute. Sandeep.
Yeah. Sorry. Sir, I will take a few minutes, means not me, for the audience and for all of you. We have a small audiovisual, because this is the platform we take to launch our paracetamol flexi bag. Just today we are launching this occasion of the World Anesthesia Day. So just we'll take 2-3 minutes. Yeah, Vinay?
Greetings from Alkem Laboratories. Doctor, as you know that Alkem is the 5th largest pharmaceutical company in India and present in all major therapy areas. Globally, Alkem is present in 56 countries and having strong presence in US market with more than 125 ANDAs. Doctor, Alkem Laboratories has 14 brands in the top 300 brands with a strong presence in pain management. In this segment, Alkem has brands like Sumo, Enzoflam, Hospimol, Gemcal, Uprise D3 and many more. Doctor, Alkem Hospicare is the highest growing company in critical care in financial year 2020. It is perceived as the true ICU care division of Alkem. Hospicare is dedicated towards serving critical care and it stands notable among the fraternity for need of quality medicines. Doctor, pain management is an integral part of the treatment in hospital care. Paracetamol is the most preferred molecule for primary pain and fever management due to the safety profile. Available paracetamol containers are conventional and difficult to handle. Hence, need of the hour is novel approach. Paracetamol is the most widely used molecule in hospital service since 1880s. IV paracetamol reaches a significantly higher 70% maximum concentration within 15 minutes of infusion and so is one of the most favorable NSAID. A study in moderate number of patients shows that paracetamol reduces the requirement of opioids, a decrease by 14.9%. IV paracetamol has broad compatibility with other analgesics. IV paracetamol improves pain relief, expedites mobilization and rehabilitation, and reduces healthcare costs. Introducing a novel drug delivery system. Hospimol FlexiBag ensures quality with flexibility. Dr. Hospimol FlexiBag offers closed infusion system to maintain aseptic conditions. Hospimol FlexiBag has 2 ports, hence no external venting is required. Dr. Hospimol FlexiBag is a self-collapsible or flexible non-PVC bag which provides greater durability. Hospimol FlexiBag is also environment-friendly. Unlike other PVC bags, it does not release toxins of HCl and is DEHP-free. Dr. Hospimol FlexiBag is easier to dispose as compared to other containers. Hospimol FlexiBag has reduced weight and there are no chances of breakage. Dr. Hospimol FlexiBag provides triple E benefit: ease of handling, ease of storage, and ease on environment. Doctor, please prescribe Hospimol FlexiBag to your next patient to ensure quality with flexibility. Doctor, Hospimol FlexiBag is available in your hospital pharmacy.
Thank you. Thank you once again. Thanks a lot, Dr. Mehta, for being there for so long. Dr. Malviya, Dr. Das, Dr. TNS, Dr. Ranveer Tyagi, and Dr. Jirpe. So I'm really thankful personally to come just in one call. And we would like to wish great success of the new introductions. And we'll be in touch with you very soon. This is a fantastic discussion on the pain management, and definitely audience has been benefited out of that. Thank you very much. Thanks a lot.
Thank you. Thank you, everybody.
Thank you. I wish all the success for Hospimol.
Thank you, sir.
Thank you, Sandeep.
Thank
All the
you.
best.
Thank you.
Thank
very
you.
much. Thank you.
Thank you, everyone. Thank you, Dr. Mehta.
Thank you,
Take
Doctor.
care. Thank you.
Thank you, Dr. Mehta, Hemant.
Hi, good
Thank you,
night.
Dr. Deepak. Thank you, Dr. Das.
Thank you.
Dr. TNS.
Thank you, everybody. Thank you, everybody.
Thank you, Dr. Tyagi.
Namaste,
Thank
madam.
you.
Vibhuti.
Namaste
Thank you.
once again.
Nice
Bye.
to see you all. We enjoyed